Let's talk about health matters now. And we want to interrogate our health budget. We're asking the question, what's at stake? And we want to do this line by line because it's easy to look at things from a holistic sense and say, oh, year on year, health budget has increased like this, like that.
Yeah.
What does that mean for primary health care? What does it mean for chronic illnesses and emergency care as well? What does it mean for preventive, which is still part of the primary, right?
Correct.
And what does it mean to you as a SHA contributor and as a Kenyan? Let's talk to Dr. Matiko Riro on exactly that. Good morning, Doc.
Good morning.
How are you?
Quite good. Yourself?
Niko poa, can't complain.
Yeah.
We always start off with the quote of the day. So
Yes,
Phalaris will share the quote, say if it speaks to you, if you agree or disagree.
Okay, good.
Fantastic. Today's quote is courtesy of Nelson Mandela. Very straightforward. It only seems impossible until it is done. How does that speak to you, especially within the context of what we are going to be discussing in this hour?
Yeah, I think to a large extent, so health sector is quite complex. And for those of us who've been on both sides, on being a healthcare provider, it's providing healthcare, then being on the policy side. It's quite complex in how do we get the money all the way to deliver the services down there, but finally it just has to be done. And those of us who are shaping that, it's very important that we think about it that way positively. Because then if we are not that optimistic, then it's easy to give up, especially when you're seeing all these news items about what happens in hospitals, patients being retained or patients not accessing care. Then it's something that we continuously have to think about the possibilities. Yeah,
I love that. Like Mariam said, it's good that we ground this conversation on numbers and then proceed from there. So I'll just look at what the health budget for this year looks like and their allocation line item. So we have the total healthcare sector budget. The allocation given is 177.2 billion. Correct? And this is up from 138 in the last financial year. So this is a 39 billion increase. And this was a headline number, by the way, in the entirety of this budget. Then we have Department of Medical Services getting an allocation of 132.9 billion. And that is where the bulk of the budget sits.
Good.
And this gets to cover hospitals, specialist care, and national health infrastructure. Then we have Department of Public Health that got 42.6 billion. And this covers prevention, immunization, community health, and this is often the neglected side of healthcare, and we'll get into that and just see if that number is okay. We have referral hospitals getting 45.3 billion, and this goes towards Kenyatta, Moi, and other national referral hospitals. We have UHC that got 19.1 billion, and this is to directly fund the UHC program. So again, the question here being, what does this buy? We have UHC health worker transition that got 8.9 billion. We have KEMSA, which covers medicines and commodities, 20.9 billion. We have Global Fund, and this is on HIV, malaria, and TB. That got 18.5, and this again we'll get to look at because the withdrawal of donor funding and how this is bridging that gap. We have medical interns that are covered with 9.3 billion. KMTC got 10.9. Community health promoters getting 3.2. Emergency chronic and critical illness fund getting 3 billion. Sorry. Then we have reproductive, maternal, newborn, and child health getting 3.8. KEMRI research alone getting 3 billion. And we have the cancer unit getting 300 million. Blood transfusion services getting close to $1 billion. That's 853 million.
Sorry, cancer, you said how much?
Cancer got 300 million. Yes.
Okay.
And we have blood transfusion services getting 853. Burns and Pediatric Center at the KNH getting 470. And finally, we have communicable diseases getting 4.75 billion. And this is outside the Global Fund channel. That's on TB and HIV. So many numbers there. But we need to be able to substantiate what these numbers mean to Kenyans.
Good. Yeah, I think, it's easy to get lost in the numbers. And I think for me, what my take would be, and especially for the broader audience, Kenyans, it's easy to talk about the big numbers, but it's how that translates to the services being provided to the patients. So first off, it's good to also know that the figure 1.177 billion, it's reflective of the national level interventions that we are talking about. We're yet to get to the county budgets. You know, the Division of Revenue Act that goes after all these conversations should define what counties will get. And then what the next conversation becomes, how do we then go to the counties and ask them to actually allocate more to health? Health being one of the most arguably devolved function of all the many other sectors, accounts for a bigger chunk of that budget. And once it gets there is how much are we actually allocating to health service provision. A bigger chunk of it actually is actually going back to, you know, what we call recurrent expenditures. Is how do we make sure that we work around it to actually feed into some of the outcomes of interest that we're looking at. So that I think that's a starting point of thinking about the figures, that there's a national figure, but then there's a county figure that accounts for a bigger chunk of the population.
Right.
When it comes down to what you mentioned around a couple of other areas, let's say, you know, SHA, which I think right now also accounts for a bigger chunk of money that goes all the way to the facilities. So everyone is talking about, there's actually an increased amount of money going to facilities based on one, there's more money now, especially from the SHIF, based on the contributions of 2.75. There's also, as you rightly put it, PHC fund has received a boost of funds that are going there, and the ECCIF. This actually translates to the facilities having more money.
You can't say PHC and CCIF. We have to.
Okay, so that is the primary healthcare fund, and then there is the emergency and chronic illnesses fund. So these two, which one of the figures that you've mentioned, actually go all the way to the facilities. But once it gets there, what happens? So how do we hold the facilities accountable in terms of how well that money is spent to actually translate to health outcomes? But the other bit is, how do we shape the laws, especially at the counties, to give facilities more autonomy, such that it's not enough when I have money at the facilities, but I have to get the money back to the county revenue fund. That let me have the autonomy to have the money, then use it to plan. But some of the complaints that have been coming from a number of facilities is the more money we're getting from SHA, then the more the counties are cutting back on what we deserve from the equitable share. And so how are we balancing these two such that we are not crowding out what the intention was? Can SHA be additive instead of coming and then you're substituting what was supposed to be there? So how that translates the figures is we need to go back and say, do they actually tear down to this sort of the patients being seen? So what have we been doing at Savannah Global Health Institute to address some of these items is money is flowing in all manner of ways to the facilities, but the bit that we've been supporting the Ministry of Health is build what we're calling a digital public infrastructure for health planning. That can we digitize the process where we have money flowing to the health facilities in all these fragmented channels. Once it gets there, are we able to come back and say, what did it actually buy? So health data is being generated, and so budgets are good, but if we are not aligning to what are we actually buying in terms of enabling access, then we might not be achieving much at that. So let's hold more accountable in terms of what are we getting out of all these figures by clearly going back and saying, did a mother in Turkana get impacted? Did we have a live birth that both mom and child were alive in whichever constituency or county that we are talking about? So that kind of conversation is what should be more important after the headline figures that we're talking about.
Thank you for putting it in context like that. I want to go back to basics because we sometimes have these high-level conversations, or I'm not saying this one is, but you know what I mean, which are very outward-looking, but we don't understand the basics. And I think when it comes to our healthcare system, there's still gaps. I think people are beginning to understand now how the referral system works, how I should start. We always make the joke of, ukiwa na homa usiende KNH, sawa. People have, I think, understood that now.
Yes, please.
But the funding bit, that's a whole other animal. So walk me through level 1, CHP, all the way to referral. Who is funding what at what stage?
Okay, fantastic. So the Kenyan health system in terms of levels is organized in 6 levels. So level 1, what we call the community health, community level, is where now we are having the community health promoters or CHPs. So there's a whole mandate that they have in terms of what they're going to do, provide certain test kits. So, and again, it's a whole point of conversation around how well equipped are they and how are we organized in terms of just optimizing their services.
Even just hold there. I didn't know that. So nitakuangalia blood sugar, sijui blood pressure, sijui STD, HIV, I can CHP anafaa kuwa na hizo vitu on hand.
There's a given scope of work they'll be given, but what has traditionally been is a very fragmented CHP platform where I'm interested in malaria, so I fund this area for them to go out and get the nets out. I'm interested in this. But what that ends up happening is we don't have them do some of the broader issues that are not funded, especially by donors. So mental health and some of the non-communicable diseases then suffer quite a bit because then we don't have a kind of funding. But streamlining this, which currently is the sort of ambition, enables us to get them have some sort of a package of the bare essentials, not for them to be the primary providers, but can they identify and refer? Because the biggest challenge sometimes is, do I have the knowledge or do I have the basics to understand where to seek care or when to seek care? And especially when you're talking about pregnant mothers, a bigger chunk of them are not getting to antenatal care. So can we channel them for antenatal care? And once antenatal care is done, can we channel them for deliveries on where that delivery can be done safely and when to identify what sort of symptoms need to seek care. So that kind of work then is what we should be equipping community health promoters to do.
Okay. Two things.
Yes.
Who is a community health promoter? Like, who qualifies to be a community health promoter? And then number 2, you're saying we're still having trouble with now transitioning moms into antenatal care, but we were here with PSO Luga just the other day, and he said, and from his numbers, we've done quite well as far as getting moms to clinic. It is how many times they visit the clinic, that's not the question, and deliveries also happening in hospital.
Good. So so first let me start with the question around what does it take to be a community health promoter. I think there's a clear sort of scope that has been defined. And currently Kenya divided into around 316 primary care networks, what we call PCNs, which essentially is at sub-county level. So each of the PCNs have a way in which they coordinate their CHP network to ensure that there's a sort of a coherent referral mechanism within which they work, the equipment and how they communicate to get the patients to where they're supposed to be. So that's how that whole space is organized. But when you're looking to the pregnant mothers seeking ANC, there are a couple of ways in which we can look at it, especially to address the problem. Remember, we need to get them at least go for ANC for any sort of risks to be identified early enough so that they are channeled appropriately to care. We're doing well in ANC attendance. The bigger problem right now lies into once they have done everything, they get to the health facility, skilled birth attendance is lower, but then still mothers are dying in health facilities. I think that becomes a challenge. And I know you've been seeing this new initiative, what is called the Rapid Results Initiative, to drive down, some maternal mortality, because the bigger challenge currently is the quality of care that the mothers are receiving. A lot of people currently are saying, yes, we enabled mothers to go to ANC, we enabled them to health facilities, but we didn't equip the facilities to deliver them safely. So if there's any sort of investment, then we should be thinking about is how are we working with the mother right from the time the mother comes to the ANC clinic, all the way to helping her deliver safely, walk home with herself alive, with a live baby. And there are a couple of interventions that have been put in place so far. And I know part of the interventions that we've been supporting is how do we even institutionalize items like, point of care ultrasound that identifies the risk and channels mothers appropriately. How can we democratize that at scale? That a mother knows, is my baby alive? Is the heart rate okay? Where is the lie? Can I get the service that I need? So there are a couple of interventions that have been, but it's around how we get them there. And still that goes back to the budgets, because it's around, are we actually investing in all these interventions that enable the mother to walk all the way?
This is how much was put for maternal? 3.8 billion. 3.8 billion shillings. And again, we had that conversation with CSO Luke about how this would be used. A lot of it is also going towards medicine for postpartum hemorrhage and things like that. So some interventions are happening there. We're just about to take a short break. But when we come back, I want us to do red flags, green flags.
Okay.
We've done it with budget. Now let's like zero in to the health budget. And you can tell us which line items should be getting more. I don't think any should be getting less. That would be very hard to even to put across. But let's take a very short break. Then we'll come back with Dr. Riro and talk about what's at stake as far as Kenya's healthcare budget. Riro, on what exactly is at stake as far as Kenya's healthcare budget is concerned. We'll also sample a little bit of your feedback on the YouTubes.
Absolutely. Diving back in, I'm very interested in just our funding model. We've always had at the back of our minds that we have aid and donors that are going to help us bridge the budgeting gaps. Then, lo and behold, last year happens, President Trump comes in and says, nope, I'm withdrawing from these programs and you guys have to figure yourselves out. So now you have a deficit and a gap in the budget. Now, as much as this year's health budget has gone up, we are still not bridging that gap in its entirety. So we're still working within a deficit. But even the way the entire our entire healthcare system is structured, it is, again, leaning heavy on donor funding. So I don't know at what point we'd be able to move ourselves 100% to being self-reliant when it comes to healthcare. Is it even possible? I'll go back to 25 years ago. Was it 25 or 15? Abuja Declaration, where it says X% of your national budget ought to be going towards healthcare. Should go. We're barely hitting those numbers. Barely. What does it take for Kenya to have a healthcare funding system that is self-reliant and not one that, tends to look to the West or wherever the money would be coming from?
I think back to the donor transition, especially what happened last year, is definitely something that we've been talking about for the last maybe 10 years. There's been a long conversation around let's prepare for that transition because it started, dwindling probably about 10 years ago when the decline in terms of the other bilaterals, it's not only the US, but countries like the UK and others had started the whole journey around reducing the funding to the country. So it's something that has been coming, but I think it's around how seriously are we taking that conversation and how prepared we were to the point when this will happen. Only that it happened by, one person woke up one day and pulled a plug. So there was no warning, like it's coming next week or next year.
Correct.
Is it good or bad? But I think it's something for us to think about and say, were we waiting for that moment or were we actually preparing for that moment when this will come? So clearly we were not prepared for it.
We were caught flat-footed.
We were caught flat-footed.
We're
So
just
now,
like, no, they'll always be here. They'll always be here.
when someone in your house is, someone literally drops food in your house every morning.
Wow.
And you got accustomed to it. And one day when they stop, then you actually start blaming them.
Right.
Like, why are you not here?
It's actually very un-African of us now that I think about it. Like, imagine in an African household, you go to eat in the neighbor's house every day. You would get whooped. You're always going to eat lunch at the neighbor's house. Every lunchtime you're at the neighbor's house. It's a beating you're asking for.
But what about if they're actually dropping you the food? It's not you going. How does that sound?
I don't know.
So for that, then what we've got into is a wake up call. Really, I don't think I'll blame it as much, and especially for those of us working in the policy space, we're having a very interesting conversation. And I know broadly right now we're talking about sovereignty. We're saying essentially Christian does health sovereignty. Like, how can countries own their own healthcare and drive? By owning it means you're actually putting in money and you're actually prioritizing based on your own priorities. Because the other thing that we can't absolve what has largely been the donor-funded landscape, it had stripped most countries of their own sort of sovereignty and prioritization process around what we actually want for you to do. So despite the fact that right now what we're experiencing is sort of a disproportionately higher non-communicable diseases, the way the donor funding was was actually channeled was more preferences to what was infectious, especially the three big diseases, HIV, TB, malaria, without acknowledging that right now, cancer cases, hypertension and others are rising. So there is no one who was looking at these areas. And so it's a wake-up call for us to step back and say, could we integrate all these services to a broader health system such that we address all the health areas that actually exist? So part of that is, let's prioritize, let's own our health system. But it's not to say that we kick everyone out. Let's collaborate with others, because there's so much to gain from whoever that we're talking about. So if it's the US government or even, the bigger financing facilities such as Gavi, Global Fund, they still have a role to play in terms of driving some of the health systems. But how do we steer away from just these verticals of the one disease and think about building a stronger health system? Because when you're building verticals and we're building many health systems within the same health system, and what that means is the patient who comes, if, for example, I come in as a pregnant woman, have HIV, the priority is on your HIV, but we're not looking at, we actually need to think about your delivery. If I come in as this 60-year-old gentleman, TB, no one looks back and says, but hypertensive, I'm also diabetic. How do we address all the problems at the same time? So that could actually have some, what we call efficiency gains. If we could just have this patient being treated, because right now what it is this patient has to go through 3 health systems. To go through TB health system, go through a hypertensive health system and diabetic. And all these are treated differently, and there is a lot of loss that we have in terms of opportunity cost to treat them well.
I quite like that way. That integration is so necessary. I'd not thought about it like as having parallel health systems, but then the funding again follows the function, which is to komeze malaria, TB na tiba and so on. I want to get back to the question on red and green flags and within our healthcare budget for this year, and what you've talked about as well as non-communicable diseases growing. Does this healthcare budget speak to the fact that non-communicables are increasing and we're able to do more? Are we able to do more from a preventive point of view as far as the budget looks like right now?
So if you look at, especially around what I'll call the red flag in the budget, is just, if you go to the allocations to the different departments or allocations to what the referral facilities and all, disproportionately we have quite a high sort of allocation around that. What that then means, we are preparing hospitals for people to come. So the investments downstream, especially around CHPs, around the primary healthcare fund and others, we've not put in as much. And yet for us to do that, we need to continuously imagine how do we prevent patients or even the population from coming from the hospital. And that means we need to invest just downstream as much as we can. So when you look at the figures, probably could do better in investing downstream. But what is the green flag? The green flag is if you go back maybe 10 years prior to this, some of these budget lines didn't exist, especially around, do we actually have clear PHC fund in the budget? Do you have clear around cancer setting some of the units or some of the cancer centers, or even issues around commodities availability, because that's one of the key items. So moving forward and clearly outlining this as budget lines is some of the things that we should be quite happy about. But the bit is, how do we make sure that we squeeze and get it more? Especially some of the aspects you've said is, yes, we have 6.1%. How does that reflect in terms of the aspirations of 15%?
Right. Yes.
So how do we make sure that we invest more so that even the pie is bigger for the many health areas to benefit?
There's a number of things here. One being the allocation that has been made towards paying, let me just pull this up, the payment of health workers, So you have 8.9 billion allocation that has gone towards absorbing health workers previously on donor payroll. And the question here being, for a number that is almost 42,000, is that allocation enough? And I ask this because one of the key concerns we've had from this particular sector is the amount of brain drain that is either going towards private sector or outside the country, just because these medics are not earning enough. If you split that 8.9 billion across, they're barely making bank to be able to live properly. And one of the key issues that you've identified, say, at community level is the lack of experienced workers. But what is the incentive that we're providing for them to actually go work in those centers if we're not paying them enough? So, of course, if you're weighing two options here and you have one that allows you to go live in a different country, get compensated properly, then that becomes the automatic option. So are we investing enough in terms of how much it is we're paying health workers, and what more can be done that is not reliant on donors?
Good. I think I think it's first to acknowledge that is a good starting point, that we acknowledging that people actually lost jobs where during the, all this conversation they're having about donor transition. It's not actually just about losing jobs. It means there were less health workers to provide care where there was need. So it's around going back and saying, was there a real gap that was being filled? We are admitting and saying yes. Could we go back and fill it through our own funds to actually do that? I think that's a good thing in the right direction.
True.
But around the follow-up questions around, are we actually investing? I think there's been an effort, but it's not as much as we'll think about it. Remember, again, these are cadres. It's easy to, especially for me as a medical doctor, to think from a selfish point of view and say, then we should employ more doctors. But again, when you look at the care cascade, we actually need all cadres, all the way from the specialist doctors all the way down to the community health promoters. So when we're looking at the 8.9 billion, it's actually cutting across all this. So it's not just centered around doctors. But we could do that. But what are the drivers to what we call brain drain from public sector to private sector or abroad? There are a couple of them, and some of them could be even beyond monetary. So some of them could be that, Phalaris wants to work in a well-equipped facility that actually motivates them, provides all the equipment for them to do it. Are we equipping facilities to meet the needs? Because there's no need of me being a neonatologist, but actually the newborn unit is not well equipped, then what reason do I have to stay in this space to do that? So there are a couple of things that we need to do around just matching the infrastructure with the training that most of them do have.
Or if Alaris wants to do her master's and specialize, but getting a study leave is a problem.
Is a problem. So those are some of the things that we could think about. And then, of course, it does not understate the fact that there's need to start reviewing in terms of how do we motivate and probably link some very creative ways. How do we reward more to those who do more? And especially around linking all this to outcomes. Because it's very easy to say, let's have a blanket sort of payments, but how do we even incentivize? How do you incentivize people to go to rural areas, for example? Because then what that tends to happen is everyone then it tends to come to the city.
Kuna hardship allowance?
Yes, but is it enough to the people that we're talking about? Or is it the only incentive we can talk about? We're saying we can equate all that to money, or is it about do we even provide housing for them? Do we provide other elements for the health workers that are working? So there are quite a couple of things that we could do, because it's not enough to have all that. We could increase all the pay, but have all of them in Nairobi, Kisumu, Mombasa, Nakuru. Then that doesn't help the majority of the population that stay in rural areas.
That's very true. Our numbers as far as how much we're giving to KEMSA are also quite big. And I don't know the trickle down. So I'm looking at a few headlines that I've seen over the last year or so. Auditor General reports on expiry of medicines while they're either at warehouses or at facilities, whether it's pilferage or something else. And there's just a lot of gaps. But I want to know how we're funding essentially medical supplies and what gaps exist therein. Where can we close the loopholes?
Good. So the funding, I think it's interesting to also look at, even step back from KEMS and think about commodities. Remember, the whole aim is, can we ensure that we have the commodities needed at health facilities? And these are coming from many channels. And KEMSA being essentially the main central store for the government, then is one of the areas that we should actually invest in. But what are the investments that we're making that could potentially help us even streamline that? That it's one thing to say we're putting in money, but what sort of systems are we putting in place to be able to focus and quantify what is actually needed?
True.
And are we actually responding to the needs of the population? Are we linking linking the health data we're generating from facilities to inform procurement of commodities, even at KEMSA level. So if we are not doing that, then we answer questions like
That's
all
why
these
things are expiring.
Did we actually link that to the need that was there at the population level?
Yeah.
And after that, then we address the whole issue around linking the county needs to the KEMSA needs. And then are they actually allocating money? I know the other bit probably that maybe has not come out to this is the headlines around debts.
Yes.
So counties
Or KEMSA a lot of money.
A lot of money.
So it's around how are we very strategic in the counties themselves, not only thinking about, because it's very easy then to say you supplied with medicines but went and had to invest in other things, but it's around how do we align the county budgets and what that looks like, especially around the KEMSA debts that they do have. And which other modalities are we having? Because one of the county complaints that has always been there is that the KEMSA fill rates, because most of them are saying, yes, we're using this as a first point of call, but they're not giving us as much that we need at the point of need that we have. So it's also thinking about how we balance the relationship that exists between the last mile, because after all is said and done, we can say all these things around this, but we want a mother who goes to hospital have access to commodity. If you're talking about, I want an anti-malarial, can it be there at the time of need? Or am I going to be given a prescription to go to the nearby facility? Because the bit, those of us who advocate for UHC is to make sure that people do not seek care by the ability to pay, but just the need that they do have, that we actually at the point where the health system meets our needs to this point. And health commodities are this pillar that we don't handle well, they drive up out-of-pocket expenditure. Because then if they're not available at health facilities, what ends up happening is I need to go to the nearby pharmacy to buy that.
I was going to say, I giggled when you said that because usually the nearby pharmacy is owned by someone.
Someone in that hospital.
You're like, umeniambia naweza pata tu hapo peke yake.
Because also they know the most common drugs that, you know, the issues that are coming from this facility. Man, and you know, this KEMSA issue, it's such a touchy conversation,
really is.
Because the big question here then would be, have the procurement issues within KEMSA fundamentally changed by the time we're increasing the allocation? And, you know, we are pumping money into this institution, no problem, but the accountability mechanisms that ought to exist and would then... we shouldn't cut short that money, but I think the accountability aspect has to be looked at. And directly, of course, related to KEMSA would be matters research and the allocation that has been put towards research. At some point, speaking to KEMRI people, they're saying, listen, we are still grossly underfunded and we are not able to do as much. Now we have Ebola. That you know has been a headline for so many weeks, and the region being very reliant on our labs to send in samples for investigation, for research. So it shows us that we have a very good opportunity here. We're already a hub, but we need to be able to build capacity within that space. Is this a thing that then we should just leave to donors to just fund research? And what would be the disadvantage of that? Because speaking to doctors within that space will tell you, then that means we do not have sovereignty over data that is coming from us. How would we need to shift the way we look at medical research and how we are funding it?
Good. I think first is identifying that do we, at a policy level, appreciate the value of research? Starting from there is around, are we then using research or, evidence to generate some of the policy changes? And before we appreciate that, then it's harder for us to prioritize it. But it's something that we should think about. Like, are we changing policy based on real world evidence that exists within our context? Or then we're using what has been generated elsewhere? Remember, something else that comes up, if you don't define your own, if you don't fund it, then you can't define your priorities for research. True. So if I want to fund you, then you have to feed my interests in terms of the priorities that I do have. And so what that has driven is it has skewed the kind of approach or priorities that we do have. So you'll find some of the local problems then are put in the back burner in terms of how we can actually, change all this. Probably the question that you asked earlier around the location of pharmacies near the facilities could be a whole point of research. But because we don't fund it, so we can't define it as a problem. I feel currently, as they rightfully put it, it's grossly underfunded. Medical research, and so that has given that gap of it being defined. We can't define the topic of discussion right now in research, and that is defined by external players to do that. And so we generate that data.
We kind of circle around malaria, HIV, TB, malaria, HIV, TB.
Yes.
And given that they are problems, but yes. I see what you mean. Yeah. There's a lot more.
There's a lot more problems that we could actually research on, but we can't define it because we don't fund it. Yeah.
Yo.
What would it's do we have the capacity to fully fund? I think for me it still comes down to how do we fully eliminate the donor aspect of anything as a country, as a continent? Because it almost, we are like, okay, yeah, we are not able to do it, so we just make that the automatic fallback. Research, seeing that there's so many things that are coming from this continent, also in terms of treating specific conditions, specific to our I don't want to say our DNA, but there's the peculiarities of who we are, and not so reliant on research that again is coming from the West. Is how do we treat, say, X condition, hypertension within the African context? I don't know, how would we remove ourselves from that trip?
Endometriosis is more prevalent in Black women.
Yes.
Sickle cell more prevalent in Black people. And so on.
Good. I think so. One is, I don't think we could 100% eliminate. Maybe the changing, it might not be the donors, but more partners. Yes. Let's shift more to collaborators than sitting back and waiting to be given. Just what I said earlier around the neighbor who drops food by every morning. But we're saying we can actually share and help each other build the source of food so that we can all put together. Research is one of those areas that we can never totally eliminate collaboration because there are certain expertise and resources that exist in the global north that we really need to tap into. But we should, first of all, go into the table as partners based on the fact that we actually invested in it. If I'm coming to your house and you're saying you only eat minji, then you need to put in money so that we both eat minji. But if you're saying you don't eat, you only eat minji, but you don't have the money, then you might have to eat injahe. Okay? So that's the kind of conversation that we need to have. And that what I come with is what we eat because it put in. So let's build more to collaborations, and that can be empowered more if we put in more money to the research.
I quite like that. We're just about to take a break, but when we come back, I want to get into counties now because we've had a look at the national healthcare budget. It's 47 counties. We can't go through all their line items. That would take several days. But I just want to know from a broader perspective what counties are doing well, what counties are doing right by their citizens, and what needs to be done as far as the healthcare services that are devolved and how we fund them continually. We'll talk about that in just a minute, but we do see your feedback. Just going through fixers, or the fixers asking about our signal, by the way. You can still find us on YouTube. Like we said, our engineers are working on it. So I know on Signet and
on Signet,
on Signet, you're not able to find us right now, but we do see you on YouTube. So kindly, you can just stick to YouTube until we give you the all clear, but it is being worked on. On funding matters, the other question was asking exactly how we continue to sustain our healthcare system's robustness, and I think you've answered that in quite a number of ways. And then the fact that salaries and wages, again, are such a big component of our healthcare funding system. But is this, maybe just as we go into the break, is this one of the areas where we shouldn't be worried about a high wage bill because it's so key to our health as a nation? Is this one of the areas where we can just, let's not look at wage bill? If you're telling me about parliament, I can go in, but then usually when you're telling me doctors want more, I'm just like, okay, cool. Clinical officers, sour.
You gotta pay the doctors.
Shikeni. That's it.
Yeah. I think the question of wage bill should always be balanced with how much are we actually investing. And sometimes we forget that at the national level, sort of allocation budget estimates, it weighs down to just how you do in your house. If you're saying there's too much for food, essentially means, so should we stop eating and pay school fees, or should we rationalize in terms of what choices you're making on schools and the food? So it's less rationalize and prioritize what we actually need to do. If we are investing quite a bit of time then saying, oh, we're actually measuring wage bill against infrastructure development, or we're doing big mammoth centers that we don't have the capacity to equip, then that's a whole other conversation that we can have and say, how should we shape that? And even that, then the next bit is, are we taking the health workers where they're needed? So it's not enough to say that we're pumping in money to do that, but are we actually addressing the whole bit around these equity considerations? We can increase as much, but when we keep them high up, or we keep them to the super specialized in high up facilities, then we starve the primary care facilities of the needed staff. So how do we distribute that and make sure that we're addressing? Remember, the end goal in any sort of health investments is improved health outcomes. It has nothing to do with, because we're not a bank, we're not putting money to gain other money. We are putting in money to gain more health. So continuously, let's see, yes, the wage bill is high. Are we getting from so how are we measuring what we're getting out of it? But if we sit back and say we are spending too much and then go home and sit without, having a bigger question around, yes, we're putting in, but what are we getting out of it? Then it might be a long conversation.
That's a very holistic outlook. Let's take a very short break. When we come back, we'll talk about counties and how they're dealing with matters healthcare and the finances therein. We'll also be going live to a conversation that Zainab Ismail is having with CS Joho around matters oceans at our ocean conference. We'll be right back after this. Hashtag is Fixing the Nation NTV. Welcome to the final hour of Fixing the Nation. We are live on NTV, on Nation FM, on YouTube, anywhere with a broadcast or internet signal. A very good morning to you from myself, Mariam Bishar, Felari Somboy, and Eric Latif in absentia. We're continuing our conversation around healthcare financing and what's at stake as far as this year's health budgets are concerned. And of course, we have Dr. Riro with us, and we were just about to pivot to matters county, and the fact that we can't go through all 47 counties and their individual budgets, but we just want to know what the counties are getting right, what the counties are getting wrong, where there's room for intervention, and where counties fall in this 1, 2, 3, 4, 5, 6 structure. Which part are they funding? Dr. Ayu?
Good. I think, first of all, to define which county is doing better, there are a couple of measures, because it's not one to say they are doing better than the others, but there are a couple of ways we can look at it. The first area, which I highlighted earlier, is let's be very clear that the goal is to save more lives. So then we have to go and look at measures and say which counties are doing better in certain metrics. So if we go back and look at one metrics around maternal mortality, so which county is doing better around that? So when you look at that and go back to the census, which is the latest data that we do have, then counties like Nyeri have the lowest sort of maternal mortality. So if you look at that measure, then that wins. But then when you go back and say, but let's go back up and say, which county is doing better in terms of allocation to health? So then we go back and say, what are some of the sort of thresholds that have been set around allocating more to health? I think there's been a broader recommendation at national level, not really cast on stone, that counties allocate at least 30% of their budgets to health, based on the fact that health is one of the most devolved functions. So then we go back and say if we go back to the counties have allocated more than 30%, or at least got close to 30%, then that's something we should loud about. The other bit that we need to think about is especially around SHA enrollment. Because the SHA enrollment is a marker of then how much access you have to primary healthcare fund. So counties that have done that quite significantly, sort of deserve to be lauded, because then they have improved access to care, and especially removed barriers to financial access to care. And then we go to elements around digitization, because then it's becoming more apparent that as much as we're saying let's improve infrastructure, let's get more health workers, we need to think about which other ways can we deliver care without necessarily having to have this very infrastructure investments and
Yeah.
millions of health workers to put in. I think counties like Murang'a have been lauded for that sort of approach to improving digitization. So I want to say that as we look at the counties in terms of investments in health, there are a couple of metrics that you've got to think about. And so call on counties and say, can we think about areas that we're looking at? And more so around how much are we even giving facility autonomy to drive healthcare delivery at that point? Because when we do all that, if that does not translate to a mother walking into a facility and finding a midwife who is well equipped with the delivery kits and all the medicines, then all that does not give us what we want as the ultimate goal of having to save lives. Yeah.
You know, as we every time we have conversations around public health,
Yeah.
and you bring in the money aspect, the gap between the Kenyans that seek private healthcare and public healthcare becomes more and more palpable.
Yeah.
It is so wide, and I always wonder, especially with the budget that we have, and also just looking at granulating it to counties, are we further widening that gap in true reality? Are we further widening that gap? If you look at the number of 177.2 billion, divide it among us Kenyans, it comes down to 3,200 shillings per Kenyan per year.
Yeah.
That is barely enough to cover if you were critically ill, admitted in hospital for medicine. It barely covers anything. That gap in itself is what maybe we should be looking at addressing.
Yeah.
How close are we to? Is there a universe that exists within Kenya's healthcare system that would help us close that gap?
Yeah. So in that universe, so if you look at the bigger picture, just to delve into the 177 billion, that then when you divide with the population of Kenya, it comes to about 3,200, which is, maybe if you translate to dollars, it's about $25 per person. And then look at that to the countries that we aspire to be, Singapore. That figure is to the thousands in dollars per person, a sort of expenditure. So if we are to think about that, the fundamental is let's just invest more. But again, part of the pushback that and justifiably so, that I get from the government counterparts is also sometimes when you look at the figure 177 billion, it's easy to forget that there is more investments to health that goes to the counties that is not accounted for in the 177. So there is more in terms of some of the money, and you talked about the investment in global fund, because part of that money then goes as a co-financing to pool money into the country to Gavi and other financing mechanisms. So when you expand that, I think we've always estimated and add to what they spend, the donors and everyone else, it comes to about 12,000 per capita. That's the whole estimate that comes to the figure. So it comes to about, we spend about 12,000 shillings, which is about $90 that we do spend per capita when you look at the whole envelope. Still very low to what to expect around that, what that could be. But moving and trying to think about, so how do we stretch that? It's also thinking about which other creative mechanisms are we coming up with. If you're saying SHA is our pathway to the healthcare, the Singapore healthcare, then let's be very intentional in terms of, especially part of the government and tax obligations around putting money to drive some of the work around the primary healthcare fund and the emergency fund. So that's the fundamentals. But also, let's hold these institutions accountable in terms of how well are they utilizing the funds once put together to actually purchase care. Remember, they've been given the mandate. You and I have contributed to the shift and given the mandate to go, the way you say, go ye and purchase care for the rest of Kenyans. So how well are they doing it? How efficient are the mechanisms? But how are we holding them accountable to ensure that every coin is actually used as it's intended to? Because you can stretch as much as you do. You can add as much more money as you can. But if we don't hold institutions accountable, that might not get as much. And so that's why we've been driving this conversation about, is not just more money for health, but we have to think about how much more health are we getting for the money. So let's stretch as much as we can to get more health.
I like that switch up, and it's good that you've even touched on value for money, but also some of the leakages which happened, and it got me thinking about, we see ghost facilities, ghost patients, ghost health workers not so much, but especially the ghost facilities and ghost patients, or what is it? Duplicitous claims to SHA, which is now becoming quite a big problem. It's like, same person was treated at 4 facilities on the same day, and not referral wise, just ta-ta-ta-ta. Or things that don't, or was it someone giving birth 3 times in a year? And not triplets. Just ridiculous things. How do we strengthen our healthcare systems against these pilferages? Because unfortunately, someone is always looking for the loophole, which is now that we have this, we have SHA, it's functional, we're doing claims digitally, and I can make some buck from there. How do we strengthen? Is it a people problem, a system problem, both, none? I
think it's broader, and I'll argue that it's it's hard for you to fix it and say it's people, it's systems, because it's a multiplicity of factors that come into play. So we look at just the problems that you've highlighted. A bigger chunk of that has to do, have we, especially from the budgeting side, so we can look at it from the planning side, the budgeting side, in terms of how well streamlined are we. I think the conversation that we at Savannah Global Health Institute have been having with the Ministry of Health is how do we build a more robust approach to the planning side of things, because we find there's a lot of duplication that comes along the way, because what I mentioned earlier around the many health systems that have been created historically. So we're coming back and helping them build what we could potentially be a game changer called the one plan, one budget, one M&E, such that we have visibly, we can have on one platform see all plans across counties, across the national government and counties, and also partners can actually view that and see if we're going to invest, then we're going to invest based on a gap identified across. But right now what is happening is, because of all this, because of it not being visible, then I could come in and fund depending on what I feel, not what actually appears as a gap, a planning gap or a funding gap. And then the budgets, how can we be very clear around the budget estimates, around how that happens? So that's at the national level and the county level trying to think about it. But when you look at what we're thinking about, especially from a SHA perspective, what you've highlighted around all this fraudulent and others, I think it's a people and systems, but sometimes it's around incentives. So if I'm incentivized to just provide more care without going back and saying what is the quality of care, then I'll submit as much. But it's around how we're shaping, especially data and digital systems, to pick what is the quality of care that I provided, and are they tight enough to a point where it points to this patient that I saw was discharged at this point, what was the outcomes? In a number of developed systems, they have actually put in sanctions on a longer stays, on a very specific task. Let's say if a normal delivery is supposed to take 3 days, then there are sanctions around certain elements. So
if you're keeping someone in day 4, you have to justify it.
You have to justify it, or you take care of it yourself as a provider. So that sort of helps them be more efficient around how that can be. Or even sanctions around when you're found fraudulently doing claims. What are the sanctions that are put in place? I think those are other bits that come, the carrot and stick in terms of how you build systems.
I'm again giggling because we do the opposite of that. I remember an expose maybe 2-3 years back about facilities, and I know this is probably very commonplace in private facilities that incentivize healthcare workers for keeping you longer. It's, and you know it anecdotally sometimes, because it's like, okay, you're being tested for 100 things, but you're not a healthcare provider, so you're not really in a position to question why do I need these 100 tests, or I'm okay to go home. Why am I being kept here? So especially from now the private lens, that is a whole other problem. So I don't even know how we. And now with SHA. Essentially, could that also be a problem? Because it's, if it's another night, then that's a little bit more, another test, a little bit more of a claim.
Bed cost.
Yes.
And absolutely. So in principle, how you pay providers defines how they behave. So if you, and it does not be, it's not only your healthcare providers, it's how you pay me. So if Felaris was paid to be like the more hours you spend in this building, the more money you get.
I will
Angekuwa
never
na
leave.
mattress, angekuwa na mattress.
Yeah,
I would
you'll
have
never
been
leave.
sleeping right here.
But if we come back and say you delivered this level of service,
Yeah.
that's what you're being paid for. That's a whole difference. Because then you tend to be like, within an hour, I can actually deliver this service, get paid for this, instead of having to stay longer. So some of the elements that we push back on, and especially in reforms, is the fee for service kind of modality of paying providers incentivizes that.
Okay.
So what people are thinking about, how can we sort of go to case-based payments or bundled payments, where we're saying you're treating a diabetic patient for this particular condition, and this is what it takes to deliver it. And so we're going to pay for this. Instead of saying, we do your thing. If the patient came in to be given this service but stayed for 10 days, we'll pay you for the 10 days, despite the fact that this service will be delivered at this. So those are other things. But again, the other bit that I think, again, speaking about this as a medical doctor, is sometimes there are many other things that come around patients that sometimes it's not as straightforward.
Yeah.
So sometimes it's understandable when healthcare providers push back, because patients, when we're creating these economic models, they don't acknowledge some of the variances that happen in patients. So I'll say a diabetic patient is treated like this, but it ignores that this diabetic patient came in to have appendectomy,
Correct.
or to have an amputation, to have this. So there are a couple of other things that we sometimes fail to.
Are
So
those
when
not things that would be easy to kind of explain?
Yeah.
And, just be like, this is a diabetic patient, but also we had to perform an
Amputation or something.
appendectomy.
Sorry.
Absolutely. So it goes back again how we set our data systems.
Yeah.
So we want to identify you as a diabetic patient, but the system remembers you as you walk through the journey. And so when this claim comes, we know that you are.
Okay.
It's a whole different system. And back to what I said earlier, that how our health system has been funded, especially from a donor perspective, there was a lot of emphasis on infectious diseases.
Yes.
What that ended up happening is our health system was set around infectious diseases. Infectious diseases are episodic, so it's around episodes. So the system does not need to remember you.
Yeah.
All through in the whole cascade as a malaria patient, but as a diabetic patient, the system needs to remember you, and that builds into the financing mechanism that we say you came in last month with this, and it has a digital print of you having visited facilities.
Right.
That when it comes to a claim of you getting an amputation, then it easily references that you've been going through the journey for the last 5 years. It's different when you don't have that system than when an amputation appears as a claim, then we don't know.
It becomes dramatic. Where we're
Becomes dramatic.
amputating.
Because we don't know the patient
Yeah.
all through the journey.
It makes me very curious about what our current data system looks
Yeah.
like and what that infrastructure looks like, because in the budget allocations, we don't have that covered, or it's not visible.
Yeah.
Maybe there's a cost, but it's an invisible cost.
Yeah.
What does it look like? Do we have a central system that if you're a doctor in Mombasa, you have a patient that you've seen that maybe was attended to in Nakuru, you'd be able to just cross-reference and see, okay, this is the history of the patient. Even when it comes to facilities, I know now SHA is where the claims are put in, the, flag or whatever. But when it comes to patient data, do we have any infrastructure that's been set up?
One thing to admit is historically it's been fragmented. So we've not
Centralized
that, but there's an effort going on currently through the Digital Health Agency to do that. That how do we pull all these electronic medical records or health management information systems to pull data into one centralized, patient shared records that we have, that when you come in today and seen in Nakuru, if the following day you go and be seen in different facilities, that can be done. Of course, it's a little bit more complex. In a number of countries, that's a whole big struggle around that, because there is also an inefficiency introduced.
Yes.
Because if you came to facility A, had a CT scan, when you go to facility B, and you didn't go with the CT scan, they might have to redo it. Because then we don't have a record of that. So there's a lot of expenditure that happens along the way, both to the patient and to arguably to the financing facility, especially when you're talking about SHA or any other insurance agency. So for us to look at, and especially from where I'm coming from, especially with our team, we're looking at how do we use data systems as a foundation for strengthening health systems, because we believe there's a stronger space for data systems in strengthening that we can do everything else, but if we don't keep following the patients, then there's quite a lot of inefficiencies that arise.
Very true. Also, even that data feeds into our research as well.
Yes.
Absolutely.
So then we're able to have research that is done for us, by us, with data backed, with our own data, as opposed to importing.
Absolutely. And not even on research only, but even in surveillance. Remember, it's easy to go back and say, we can see a trend of this particular, let's say there's increased diarrhea, for example. We go to hospital, there are these elements that you're seeing, or there's an increase in number of mothers that are delivering stillbirths. So we can look at that and maybe go back and say, are there particular areas where we're having this? Are there particular molecules or commodities you're providing these patients to enable us get this? So it can enable us identify patterns for interventions or create alerts and say, seeing quite a number of fevers, so could we be having Ebola based on some of the aspects that we talked about earlier? So building such kind of systems can enable alerts in systems for surveillance.
There's something, we've talked a little bit about how we fund non-communicable diseases. I think there's a mental health as a non-communicable disease, mental health illnesses, and looking at them. So essentially, does mental health have separate funding, or it's just it's through and through? And I know, for example, Mathare National Teaching and Referral Hospital is at level 6, but so it gets its money from national government. Then below the chain, how do you claim for mental health? How do you treat? I have so many. I just usually have so many questions. Yes,
I know. So arguably, this has been, traditionally and historically, one of the neglected areas that because people have not been talking about it historically. I think it's becoming now a topic of conversation. Remember, as I said earlier, how prioritization happens depends around how these topics come and who funds
who's
it
funding
and all
them.
this.
Yes.
So this had never been one of the areas that we're looking at, but it's increasingly becoming one of those areas. But when you look at the current delivery, especially based on the budget items that you mentioned, there's a tendency then to be very reactive and go like, let's invest in the higher level facilities without having to look back at how are we strengthening even CHPs themselves to identify and refer and create that whole channel of building a system where I see that there's something that happens, refer, but also create a system that follows them up to the sub-county hospital, to the county referral hospitals, to the national referral hospitals. But that's not enough that we got them through that. How do we maintain them in care and make sure that happens? So it's not enough that we are having all these infrastructure investments, but it's around how intentional are we in following the patient journey and keeping them at that. And especially even investing in expertise. Are we investing in mental health education for nurses, for doctors, so that they're able to identify and treat instead of having to wait to have the thousands of psychiatrists? It's good to have psychiatrists across, but again, we know that to achieve the numbers that we need, it will take quite a bit of time.
It will.
But
And investment.
And investment as well. So if we could, in the short term, invest as much in building capacity of the nurses that are at the front line to identify and probably not just treat, but refer appropriately, that would be a very important starting point.
What's triage for mental health? I always ask. What does that look like?
So I think there are a couple of algorithms that have been set, especially by the mental health department at MOH, that give some kind of what that looks like, a point by point triage, that when someone comes with 1, 2, 3, this is likely to be this. So that has already been prepared, and that's something that actually exists within health facilities. But it's around how do we scale that across the country to CHPs, to nurses in the level 2 or 3 hospitals, that then can refer upwards.
I'm curious about two things. One, cancer and the allocation that it's been given, especially at KNH, and it is Kisii. There's a facility in Kisii. Is that enough? Should we have cancer centers across all parts of this country. Might probably not be possible to have it across 47 counties, but across the major counties that are accessible and within proximity to other counties. So we have one in the northern part of the country, the western, Luo Nyanza, down towards the coast, so that there's access. Because at the moment we have a cancer burden. Even within the urban areas, you wake up and you always finding some fundraising that is going on to take someone through cancer treatments. Because then that in itself is such a problem. We might not have concrete data, hard data, because we are still feeding into it. But is the allocation of 300 million enough?
Okay, so remember in the cancer care cascade of especially when you look back and see how this happens. So at national level, there's been an investment of about over the 300 million and the cancer center that you've mentioned. The government has apportioned about 13 centers, just what we've mentioned. So what they're calling 13 cancer centers. But back to the earlier conversation, this is very upstream investments around what that looks like. But it's stepping back and going back and saying, by the time we get here, what have we invested in to this? So the blame has always been patients are coming late to treatment. And so over approximately about 70 to 80% of cancer patients in Kenya come in stage 3 and 4, which then has an impact in terms of survivorship. And the drive has been, how do we make sure that we catch them early to at least and that might mean on top of investing in cancer centers, how well are we investing downstream to screen? Because not only screening, but can we help link them to diagnostics and care early enough? In most cases, what happens, because the patients that we say that they came late, in most cases they actually came early at the first point of contact with a lump on the breast, with all this. But in terms of how well did the machine move them through the system, that's what becomes a challenge. So one of the pieces of work that we've been working with the National Cancer Institute and Roche has been around how do we build a platform, or we're calling Empower, that then looks at create awareness, link the patients to screening and diagnostics, then help navigate them through care. Remember, it's not enough that you did all this, because some of them don't know where to get that care. So this platform then enables them to look at these awareness has been created, and awareness is based on some of the protocols and guidelines provided by the National Cancer Institute, and then they are linked to diagnostics. And it's not enough that we invested some of these diagnostic equipment. Are they networked well enough to make sure that when a sample is collected as the center we're building in Kisii, and then in the nearby health center, is it able to get to the facility in good time? Because in most cases, the turnaround time of these samples moving can take up to maybe months to get the results back. So it's not enough that we've done all this, but how do we make this very smooth so that I went to the facility earlier, they got the sample, the biopsy out early, how soon did it get back? And I think that's part of the bit of work that we've been working with the team at Roche to see, with the counties as well, that how can we streamline through a hub and spoke model that enables us to move a sample from the smaller facilities, just streamline in what we're calling a digital network optimization, so that the samples are moving, that within 7 days, can we get the results back? And then care is initiated. Because there's quite a strong evidence around a delay by a month reduces survivorship by about 10%.
Wow.
So you can imagine the longer you delay, then survivorship is reduced. For us, it's been how can we cut down? First of all, shift it to stage 1, at least stage 1 and 2, bigger percentage, just as it is in some of the countries that we aspire to be. Then once that is done, then we have a higher chance of increasing survivorship. So it's that the breast cancer patient in Kenya, survivorship levels equals to the countries that we aspire to be by making sure that they come in earlier and we intervene earlier.
Diagnostics.
Correct.
Okay.
I'm seeing an opportunity for low-hanging fruit once again on telemedicine, given that we have one of the highest mobile penetration rates. Is how that would allow us to also catch some of these things. So have a lot more doctors accessible to people who are in far-flung areas that would be able to speak to a specialist, and then when they hear them out, they can actually say, okay, maybe make your way to X facility to get your diagnostics or testing. I think that.
Absolutely. And so there's that level of having to call, but there's that level of just access to information. So how do we, through whichever models that we do have, either the USSD and others, how are we actually spreading the messages and creating awareness? Because that becomes the first point. But even equipping the community health workers with basics around creating awareness to the communities, because then, and referring them on time and getting them to navigate through the healthcare system. Remember, even when you go to hospitals, if you've ever gone to one of the bigger district hospitals, there are many buildings in the hospitals. You walking around and even finding where the cancer unit is, or screening is a whole complex item. So how do we help in that whole navigation network for patients within the healthcare system?
I wanted to get into just two things before we close. One is health-seeking behavior. There's, we're doing quite a lot of work to ensure that the health system itself is robust, that we're putting money where it's needed. We're pushing, so that's one end of the stick. The other end is health-seeking behavior from us as Kenyans. What's our health-seeking behavior in your view, and what do we need to do to make a healthier nations and have healthier outcomes as far as our behavior is concerned?
So of course, it's not the best, and especially for men. But there are other interventions that we could have. What drives health-seeking? There are many other factors. One is awareness, is just awareness creation around what do you actually need. So, for example, it's very important that all of us, men who are above 40, should have screening for prostate cancer. So, first of all, that is the message that should go out there. So that's the beginning. Then the next level is the service available? Okay? And then it's good I know that. Where do I get it? When I get there, will it be there? And once I get to know this is the diagnosis, is there a pathway to me getting care? And making sure there are no barriers in that pathway.
Yes.
Because there could be like, I know where to get it, I get there, but actually I don't have the money to pay for it, and it's not covered by SHA. So that then becomes a whole bit of what is the point of making me go there and screening me when you didn't have a plan for me. And it's been this ethical conversation around, is it good to create awareness and screen when you don't have a plan for me? So you get me know that I have a lump, and that lump, you say it's cancerous, but you didn't have a plan for me. And so there are all these conversations that we need to think about here.
What now? The other, that's actually, I like the holistic and like bird's eye view you're taking. The other one I wanted to look at was alternative medicine. And I say that because I don't know how it coexists. It was part of the health-seeking behavior, which is sometimes talk about like, miti shamba for me. Don't really want none of that. Antibiotics, what is that? Nature's antibiotics.
Cinnamon. Nikikunywa clove water nitapona.
And sometimes, again, if it's a common cold, you'll probably be all right. You can tell us, doc. I mean, it's a common cold, but then it escalates to more serious things. Is there room in our health policies for working with people who operate outside the system? And I mean this, like traditionally trained midwives, for example. Daktari wa miti shamba. I'm just asking. I'm just asking.
I mean, of course, maybe I'm not the best equipped to talk about because I'm already biased. The challenge of having gone through the formal medical training, then there's a tendency to say the others are outside the system. They should come and join me in the formal training system. But I'm not saying that there's no place for it. The only piece that everyone has been talking about is how do we regulate and streamline it better in terms of what are we talking about when you're talking about alternative medicine? What are we talking about when you're talking about traditional birth attendants? How well equipped are they to address the challenges that come? Because anyone will push and say, let the mothers deliver at home. That is happening in a number of countries right now. It's pushing for home-based delivery.
Is that a thing?
Yeah. So
in the West?
In the West, It's actually a thing. Let the midwife come to where you are, and instead of, because remember, hospitals are terrible places to be, because then there are all this, you're prone to other infections that are within hospitals. So there's a drive to keep people away from hospitals. But then the challenge in our setting is, are we well equipped to address issues such as infection, neonatal sepsis? Are we equipped to address issues like, do we have vaccine? Because at birth there are these vaccines that need to be established. So there's a whole system that is set around birthing that we really need to address. And currently, we do that in health facilities. Are we ready to bring it at home? Probably at some point when all this is ready, we have addressed all these problems, that would be it. Is there a role for traditional birth attendants? Of course. But how streamlined are we for them to identify risk? Because the whole point is, what about if the mother has been pushing for 12 hours and is obstructed labor?
Right.
Do we have an ambulance nearby to take? Because in home deliveries, as it's happening in other countries in the West, there's a whole chain around creating a pathway for me, making sure that I'm at home delivering and the midwife is coming, but there's an ambulance in waiting. There's a whole system set around it that if anything goes wrong, it's actually well captured.
addressed.
So those are things
And
that we could
you're
think
within
about.
minutes of a hospital.
Absolutely. Yeah.
Okay.
Another provision that was on this budget was on critical care.
Yeah.
And we had a chat with a doctor around the health summit, and we're talking about how, first of all, there's not enough people within the critical care space, enough
Correct.
doctors,
Yeah.
and two, the capacity within hospitals to be able to fully take care of patients.
Correct.
Is that an area where we should be agitating for more allocation across all the counties?
Absolutely. And this is coming from the whole care cascade of critical care. That is from neonates, pediatrics, all the way. We are way behind in the investments that we've made, especially in ensuring that at least let us have a critical care unit in areas that we're having all these children being born.
Yeah.
Because then that could be one of the areas of assuring better health outcomes at birth. Currently, we have every day we lose more than almost 90 babies at birth.
Yes.
And what that happens then is, in most cases, the things that were not taken care of is just some aspects around, did we assure them of warmth? Did we assure them of, that's why there's quite a push to have kangaroo mother care, at least as a stopgap measure, but there's more that can be done along that cascade. Is there more?
Yeah, I was just about to ask you. Kangaroo. Sounds fun.
You know, I'm just thinking about a kangaroo and
With
a
the pouch. Exactly.
That's exactly what it is. It's you putting your baby close to the skin to keep the baby, the newborn, quite warm. Because one of the biggest killers is what we call hypothermia, so very low temperatures. Because at that point, then them creating that sort of temperature is not as good in thermoregulation. So you need to keep them just to the skin. So cover them. Basically, what a kangaroo looks like, how the kangaroo carries the babies. So that's how the mothers do carry kangaroos. So that whole cascade is how well have we invested in making sure that when we have newborns, we actually have a system that takes care of them. But also, if this happens in a health center, how well are we equipped, especially in ambulance services?
Yes.
Get them equipped to get them to the point where they can get care. And where they're getting care, there's infrastructure, there are healthcare workers that are well equipped to actually deliver that. So that we've not invested as much in that whole bit of the referral mechanism and also the referral sites having what the prerequisite kind of services to be provided to the neonates. And that also applies to the adults, because then when we don't have that at the point of referral, what happens is then we bring them here basically to die. So that's one of the elements we could be thinking about around how do we push counties, especially in their referral facilities, to have them well equipped and have a clear referral mechanism. We're not saying that all the 5,000, there are over 5,000 public facilities. So we're not saying that just have critical ICUs in all of them, but can we have the centers, the very least county referrals, better if that can be done at sub-county levels. Then we have clear referral mechanisms how this happens. And also even counties exchanging resources. We're not saying that let's have all this. But if Nakuru has this, can counties leverage on each other to share resources, especially around critical care? Can they, even in human resource, can we have shared resources? So those are things that we could think about as well.
You've done an amazing job at, again, like I said, giving us this bird's eye but very well informed look at how we're budgeting for healthcare. And I think we'll keep threading these conversations with you throughout the year, even as we implement the budget now that we have it. But thank you so much to Dr. Matiko Riro. He is, of course, from Savannah Global Health Institute, and we've been discussing what's at stake with our health budget this year. And I'm just looking at some of the feedback. A lot of people are quite happy. Jacinta says, good lesson from Dr. Matiko. I'm following from Nyamotambe. Uko ni wapi? Nyamotambe. Sounds like, no, I don't want to guess. Let me,
I'm a Jacinta anaweza tuambia huko ni wapi.
Yes. But Kelvin is also enjoying the conversation. Same to Philip. Thank you so much for your time, Daktari.
Asante sana.
All right.
Much appreciated.
You're very welcome. And again, we'll continue threading on matters healthcare. In the next few minutes, we'll be transitioning to Our Ocean in Mombasa, which is happening as promised. And it's essentially a conference happening for the first time actually in an African country, if I'm not wrong. And it is taking place in Mombasa and Kilifi from the 16th, yani leo, hadi the 18th. It's the first time this global summit is being hosted on African soil. And the event will focus on the theme, which is our ocean, our heritage, our future, uniting leaders, of course, to drive practical marine solutions and mobilize action. And I know there's quite a number of things that are being looked at for this year's summit.
At this year's summit, correct. So again, first of its kind, hosted here in the continent. And some of the key issues we'll be looking at is matters funding, given that we're here talking about money. Now, looking at the Daily Nation on page 14, before we transition over to Zainab, is 21.8 trillion shillings. Since the launch in 2014, the Global Ocean Conference has mobilized commitments valued at approximately that figure that I've mentioned, 21.8 trillion, reflecting large-scale financial pledges aimed at supporting ocean conservation and sustainable use of marine resources. We'll now quickly cross over to Zainab, who's going to be, having a chat with the PS of the Blue Economy and Mining, that's Betsy Njagi. Zainab, good morning.